So greetings, everyone. Thank you for taking the time to join us today for this very important webinar, Reimagining Healing After Harm, the Potential for Restorative Practices. But first, I'd like to take the opportunity to introduce myself. My name is Alison Koyman, and I currently serve as one of the co-chairs of Patients for Patient Safety Canada. Patients for Patient Safety Canada is a volunteer-led program of the Canadian Patient Safety Institute and the Canadian arm of the World Health Organization's Patients for Patient Safety Global Network. Patients for Patient Safety Canada is a group of volunteer patient safety advocates with a vision to improve the safety of the delivery of healthcare through their wisdom and expertise, which we have earned through the visceral lived experience of healthcare harm. I would like to take a moment to acknowledge the support that Patients for Patient Safety Canada receives from the Canadian Patient Safety Institute, and in particular, the unwavering commitment of both Iwana Popescu and Janet Bradshaw, who will be supporting the logistical pieces of this webinar today. On behalf of the Canadian Patient Safety Institute and Patients for Patient Safety Canada, I respectfully acknowledge that the Canadian Patient Safety Institute head office is located in Edmonton, a Treaty 6 territory, which is a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Inuit, and many others whose histories, languages, and cultures continue to influence our vibrant community. I am personally joining you from Coldstream, British Columbia, the ancestral, traditional, and unceded territory of the Syilx Nation. We respect the First Nation treaties made on these territories, acknowledge the harms and mistakes of the past, and dedicate ourselves to collaborate with Indigenous people in the spirit of reconciliation. Please take a moment to acknowledge the land and people from where you are situated. We invite you to join our learning journey today with humility and respect towards the past, each other's present, and possibilities for a better future where every patient experiences safe care. So I'll just give a bit of a journey or a bit of a story about my journey to get to this place. In 2012, I received an erroneous cancer diagnosis and subsequently underwent an unnecessary bilateral neck dissection. I was 30 years old at the time, and I had 4 young children. The surgery caused me a significant amount of harm, leaving me disabled and in chronic pain. I was no longer fit to practice as a licensed practical nurse. I was horribly sad. I felt incredibly depressed, even suicidal at one point, and most significantly, I felt betrayed by a healthcare system in which I had placed implicit trust. What I really needed was some help and some kindness, some humanity. This was not my experience, nor the experience of many, many others who I have gotten to know over the course of these past years as I sought answers. I thought perhaps my experience was an isolated one, that I was just unlucky and perhaps even blamed myself. What I found was that almost everyone I met could recount a story like mine. There are articles upon articles regarding the difficulties that patients have after they've been harmed, almost all of whom have struggled significantly to access information about the harm event. We call this the wall of silence, and finding support services for injured patients seems to be near impossible, despite the significant investments in care for healthcare providers post-harm events. This second unintended harm, which we refer to as compounded harm, can be equally as harmful as the patient safety incident itself. We as harmed patients are incredibly disadvantaged in this space. Despite Herculean efforts and hefty investments, we have not been able to effectively move the needle on patient safety. In the Canadian context and around the world, the third leading cause of death is patient safety incidents. And judging by the amount of interest in this webinar, many of us are grappling with how best to respond to it. So we're excited that you've joined us today in a discussion to reimagine healing after harm. Let's explore the role of reconciliation, restoration, and reparation through the programs and best practices implemented by others. Today, I have the greatest pleasure of introducing you to 4 amazing individuals who have recognized and acknowledged the significant harms that are caused by inappropriate responses to patient harm, and who are taking great steps to prevent it. Herein, I personally find hope that we, as an evolving and morally rooted society, can move forward in a kind and empathic response to patient harm. It is no longer sufficient to ask what happened and why, we must shift to also ask who is harmed and what are their needs. It is long overdue that we address the significant harms being experienced by patients and healthcare providers in the wake of medically adverse events, which has long been unaddressed. I look forward to how we can reimagine healing after healthcare harm with you. So before we get started with the presentations, I would just like to take a moment to orient you all to this virtual space that we're meeting in today. As you will note, all the lines are muted, except those of us who are presenting. This is necessary due to the sheer number of registrants. There were nearly 400 for this webinar. However, we want to encourage discussion, so please use the chat box to communicate and engage with us, and we will do our best to integrate your questions or comments. I would encourage everyone to familiarize with yourself with the chat box. Perhaps you can send a message to everyone stating where you're from if you would like. And if you do have any technical difficulties, please direct your questions to Janet Bradshaw. Iwana Popescu will also be monitoring the chat box. Just a note that the session will be recorded and will be made available publicly after the webinar, along with the slides and resources. The chat component of the webinar will not be shared. And also please note that we have extended this webinar to allow for a panel discussion after the presentation, as well as interactions between the presenters. And we will be asking you to fill out a short evaluation at the top of the hour so we can understand the value of this session and also collect ideas and areas of interest for future webinars. I also want to acknowledge that some of you may find the content of this webinar emotional or upsetting, and I encourage you to practice self-care, take a deep breath, or take a step away if you need to. My wish is that you will find the content of this webinar to inspire hope and healing. So just a quick look at the objectives for today's webinar. First off, we want to learn about innovative approaches in restoring health and repairing trust. We want to imagine better ways to respond to patient safety incidents. And we're hoping that we can offer at least one practical idea for engaging patients, families, and the public in improving patient safety. And then the agenda. So first, we're going to start off with Dr. Rob Robson, learnings from the Winnipeg Regional Health Authority. Then we'll move on to Marty Hatley, the Communication and Optimal Resolution Program. And that is, Marty is in Chicago, and Jo Whaling is in New Zealand, and she'll be talking about restorative justice and the surgical mesh, the New Zealand experience. So I will just do a quick introduction for Dr. Robert Robson. He was previously the Chief Patient Safety Character in Winnipeg. Rob now explores the tangled intersection of complexity, resilience, and safety in healthcare. He tries to help patients navigate the healthcare system as they seek reasonable answers about their care. Rob is a specialist emergency physician who continues to practice, having worked in a community hospital and tertiary care emergency department. So now I'd love to turn it over to you, Rob.
Thank you, Ali. And welcome to everybody from Dundas in Southern Ontario, which is the traditional territory of the Haudenosaunee. You'll see that I've entitled this Giving Back the Pen, and I'll explain that in a moment. That's the name of an article which I wrote with one of my colleagues, Elaine Pelche, to describe our efforts to develop a process for early compensation discussions. So let's get to the next slide, which basically just says, as far as I can tell, I don't have any financial, scientific, or ethical conflicts of interest. And what I'm going to do, next slide, please, is invite you to travel back with me to the first decade of the new millennium, specifically the time around 2003 to 2006. And look at the efforts in the Winnipeg Regional Health Authority to address some elements of the question of healing after harm, and specifically our efforts to develop a process for early compensation discussion. Before we do that, I want to just touch on a few messy details. You'll see this 3x3 presentation, and importantly, at the very middle of it, this drawing or sketch, which I have called the lost patient. It's kind of makes sense to put this in the middle of our discussion. It's an original drawing by a child psychiatrist, Dr. Jaswant Guzder. So I want to just briefly take you through these figures. You see on the top row, 11 to 1, 13 to 1, and 160,000 to 1. So I would like to invite you to come to the casino with me and determine which of these odds you would prefer. Of course, your first question will be, are those odds to win or odds to lose? So let me explain a bit further. The figure 11 to 1 and 13 to 1 refer to the risk encountered by patients entering acute care hospitals in Canada to encounter a significant adverse event with disability and, in some cases, death. And excuse me, the figure 160,000 to 1 is the risk that I encounter as an emergency physician back in 2005 to find myself served with a lawsuit. So in other words, I would have to see 160,000 patients to have to deal with a legal action against me. On the other hand, pediatric patients, 1 out of 11 of them will encounter a serious adverse event, and adult patients in Canada, 1 out of 13 will encounter a serious adverse event with significant harm or death. So the risk, you see, is not equally balanced between the risk for physicians, other healthcare providers, and facilities on the one hand, and patients. So in the second row, you see 2 figures, $50 million and $5 billion, and there's the poor lost patient in the middle. The $50 million refers to approximately what is available all across Canada at this time to support efforts to improve patient safety and reduce preventable harm. The figure of $5 billion is the sum of assets available to provide legal defense for facilities and practitioners in the healthcare system. So on the first row, you learn that the risk of being harmed is significantly higher for patients than the risk of being sued for physicians. And on the second row, you see the figures for providing support for patients, improving patient safety is drastically lower than the resources available. That's just part of the messy detail of our situation. On the bottom level, these are 3 figures that pertain to the province of British Columbia on the west coast of Canada. The first figure, 188, refers to the number of patients who died in the first 6 months of 2020 as a result of COVID. The second figure refers to the number of individuals who died in British Columbia in the first 6 months of 2020 as a result of an opiate overdose. And the third figure, which is an extrapolation, refers to the number of patients who would be expected to die as a result of a breakdown in the way healthcare services are provided. If we had more time, I would go into how this figure is derived. I think it's quite reliable. But strangely enough, we can't actually get access to reliable data to compare to the 188 or the 550 because it's not generated on a regular basis. So looking at the next slide, just to provide you a little bit of the context of what we were trying to do in Winnipeg at the time, a few of the basic principles, very important. All parties should be involved in the investigation of an adverse event that includes patients, families, healthcare providers. It's important to use appropriate methods to investigate the adverse event. I'm not going to go into this a lot of detail, but when we first started doing the work, we discovered that all of the typical linear methods like root cause analysis, revised, the alarm protocol, the London protocol, these were all unsatisfactory, and so we worked to produce a different approach. Thirdly, we thought it was extremely important that patient safety investigators should be fully trained in the way they think about and analyze adverse events. Very important that all of the parties should be involved in developing recommendations, and specifically the patients, the families, and especially healthcare providers. And something we were very lucky in Winnipeg, there needs to be active commitment of senior leadership to improving patient safety. And I can say I was somewhat of a spoiled brat. Our CEO, Dr. Brian Postal, was seriously committed to making sure that we make improvements. Finally, a very problematic area, share the learning widely. Now that should be obvious, that should be a straightforward thing, and yet it was very hard to have this accepted broadly. Even with widely, completely de-identified cases, the possibility of providing information to other facilities, even to other units within the WRHA, was initially resisted. And the most common comment that was made was, providing this information is the same thing as providing a blueprint for litigation. The strange thing is that whenever we asked legal counsel to give us examples of this having happened, they were unable to do so. So now, just briefly, the next slide, some inspiring words from one of the recognized leaders of the patient safety movement, Dr. Lucian Leape, who wrote an article in 2006. And he said there are really 4 issues that need to be addressed by facilities that want to have an impact on healing after harm. First of all, there has to be a clear policy about the disclosure of harm. And we were able to get to this stage rather early on in the Winnipeg Regional Health Authority, and the provincial government of Manitoba as well provided legislation to support that. Secondly, that staff should be trained in disclosure discussions. And this is very important because these are some of the most difficult discussions that will ever occur. And we were greatly helped by our colleagues in the Calgary Health Region, who had spent a significant amount of time working with the Institute for Healthcare Communication to train a large number of their staff, and eventually we followed their lead and trained more than 14 of our local leaders in Winnipeg and Manitoba to train other staff in disclosure discussions. The third point that Lucian Leape raised was the absolute necessity of developing effective support for patients and providers. And I'm sorry to say that we didn't do a terribly good job there. There were some interesting initial possibilities. The only way at that time to report adverse events in Winnipeg was through a 24/7 dedicated live operator line. And so people would call up and tell their story. And that line was operated from a regional health clinic, which also provided support for emotional distress and potential suicide situations. So we had very highly trained, most people with masters, counselors who were answering the phone. And whenever they took a story about a potential adverse event, they also offered the possibility of meeting with one of the counselors. But to say that we developed effective support for either patients or providers would be an extreme stretch. We fell down on that particular one. Finally, and what I wanted to touch on briefly today is the fourth point from Lucian Leape was develop a process to promote early discussion of compensation. So going on to the next slide, basically this is a reference, and that particular article is called Giving Back the Pen. There's the details, and this reference will walk you through all of the steps that we went through in order to develop this process, and it provides several interesting flow diagrams to describe in more detail. Don't really have enough time to go into the details. Just where did we get that, that title? And it comes from a comment that's attributed to Bishop Desmond Tutu, who said, if you take my pen and you say you're sorry and you don't give me back my pen, and nothing has really happened. And this addresses, in part, the issue that harm after adverse events in healthcare is not just simply material harm. There are all sorts of other levels of profound harm. And so our effort to develop a process for early compensation discussion was only one tiny step in that direction. Just very briefly, before I stop, one of the interesting things, we had our discussions with both administrative and clinical leaders within Regional Health Authority, plus lawyers from the Regional Health Authority and from Provincial Council representing physicians and from Provincial Council and National Council representing hospitals. And you can imagine that these would be interesting discussions. We had more than 10 meetings, and we encountered a number of issues which you can read about in much more detail in this article, which were issues such as how do you identify the cases where it's appropriate to have such conversations, and how do you come to an understanding of what is a reasonable amount of compensation after harm. So these were big questions, and of course the process would be one which would directly involve the harmed person, the patient family, with legal representation if they so choose. So this all sounds wonderful, and I have to tell you that we made almost no progress after hammering out all the details. It was clear that the approach to identifying cases was seen very, very differently by patient safety advocates on the one hand and families, and by legal counsel on the other. So we were able to identify only a small number of fairly obvious cases, and they worked very well. But after that, it was more and more challenging. So I think I'm going to really stop now and refer you to that article. It has a lot more of the detail. And I thank you for coming on this brief time travel back to the first decade of the 21st century. And when we get to them, I'll be happy to answer any questions that you may have. Thank you very much.
Thank you so much, Rob. I don't see any burning questions in the chat box, so I'm hoping what we'll do now is we'll move on to Marty and Carol, who are presenting on communication and optimal resolution, which may actually speak to some of the issues that were difficult to progress, which within the Winnipeg Regional Health Authority. So just a quick intro for Marty Hatley. Marty is president and CEO for Project Patient Care, a Chicago-based safety and quality improvement coalition. He also serves as the co-director of the MedStar Institute for Quality and Safety, which integrates open and honest communication strategies, patient and family engagement, research, and high reliability organization methods into quality and safety improvement. He has been active in federal health system transformation, worked as a consultant on several projects funded by Centers for Medicare and Medicaid Services, Agency for Healthcare Research and Quality, and the Patient-Centered Outcomes Research Institute. And I'm just noticing here that Marty didn't mention that he's a lawyer in this bio. And joining him to present today is Carol Hamelgarn. She's worked in the healthcare field with the industry for over 30 years. Her early years were spent in sales, interacting with private practice providers and academic institutions with medical students, interns, residents, fellows, attending nurses, and pharmacists. Following the death of her daughter, Alyssa, Carol's personal mission shifted to working with health plans, medical groups, and employers on quality improvement, disease management, and prevention programs for the patients and employees. Carol's commitment to advance change led her to get a master's degree in the field of patient safety leadership from the University of Illinois in Chicago, where she now serves as an adjunct professor teaching in the same program. Carol has a second master's degree in healthcare ethics from Creighton University. Her passion is in the area of communication and resolution programs, healthcare communication, and storytelling in healthcare. So I'm going to turn it over to you, Marty and Carol.
Thank you, Allie. Can you hear me? Great. I'm off mute successfully. Carol, can you say hello just to make sure you're off mute?
Yes. Hello, everyone.
Okay, great. Next slide, please. So we're here today to talk to you about CANDOR. And CANDOR is a little bit of a tortured acronym that stands for Communication and Optimal Resolution. And we're, listening to Rob in particular, what we had the good fortune to have in the United States is getting some feedback here, is some real investment in the research and demonstration of these tools as we put them together. Because the prevailing wind is not really with us even now. There's a lot of people that are seeing the benefits of a different approach to litigation, but we are so impaired by or impeded by our culture that you really need to prove it to people before some people believe. And we had really under the leadership of President Obama, some real investments in a number of demonstration projects, the biggest one of which was in Chicago, Illinois, where I live, to really help us kick the tires and figure out if our ideas would stand kind of the test of all the challenges. I'm really thrilled that I was not the lead of this project, but I was involved pretty much from the beginning. And one of the things that was really emblematic of our work is that we brought Carol and other people who had experienced the healthcare system failing them and their families in as co-creators of this work. So you see a wonderful quote there from Carol, which is taken from the HRQ website. And Carol is just a fantastic person who's really helped shape this work. Carol wasn't really sure whether she was going to be here for the entire webinar, so our kind of plan today is I'm going to do most of the presenting, and Carol is going to interject and editorialize, and she's fantastic at that because she's a phenomenal listener. Next slide, please. A lot of this content is actually developed by Tim McDonald. He was the lead of this project, the thought leader, the chief architect, I think, of what became the CANDOR project, which came out of all these demonstration projects. He helped us build the content for this presentation when he was a close colleague of Carol and I, and he still is, but he's moved to a different company, and that is RL Datix as the Chief Patient Safety Officer earlier this year. So we just want to acknowledge him and his contributions here because we're borrowing from his content. And of course, Carol was a key developer of this, as I said. Next slide, please. So this is the official CANDOR acronym. On my first slide, you saw a link to CANDOR. This is in the public domain. CANDOR is in the public domain. It was produced with government money, so anyone can use it. There's a number of organizations that are implementing it in a number of ways, and this is the official diagram of how CANDOR works. I'm not a huge fan of this diagram because the two really important things that really give CANDOR traction are communication and care for the caregiver. Rob mentioned both of them, and when I've asked, why that's not really more visibly called out here as the two drivers, the two change engines, I'm told that it's that little circular dial in the middle of the boxes that is where communication and care for the caregiver lives. And I think that is true, but it doesn't come forward exactly in this. I would also reverse this. The thing you have to have in your organization to make CANDOR work is that first green box, a system. You have to have this hardwired and embedded in your system so that you're ready for the box number one, a CANDOR event when it happens. If you just have good intentions, if you have a few people that have bought in, if you've trained and supported in a number of ways, but you don't really have your whole organization hardwired to make this happen and get through the rough parts of it or the frightening parts of it, it tends not to thrive. So having that system in place before your events happen is key. And we're going to talk today mostly about how you get that system in place. And then once the system is in place and you have an event, the diagram works pretty well. You go immediately as fast as possible into responding to both patients, if the patient can respond, to family, to the providers involved, because a traumatic event has happened in your organization, something that was unexpected, something that is going to create a lot of emotion and a lot of harm. And responding faster rather than slower is the key to that. You also, if you're committed to an organization that learns from its issues and gets to the bottom of why things failed, you want to start your investigation as quickly as possible. So within CANDOR, there's a real-time urgency piece to it, and it proceeds to resolution. So the diagram works well in many, many ways, but think of that little swirly thing in the middle as communication and care for the caregiver. Next slide, please. And Carol, you're going to interrupt anytime. I'm going to move pretty fast through 20 minutes, but you have an open invitation to interrupt. So the goals of this program was really to reduce harm. I mean, that's, to use a Canadian analogy, that's the puck that we keep our eye on. That is our core goal. And the danger, I want to emphasize that because the danger is thinking of this as a liability reduction program. There are a number of consultants out there who are prone to try to save the systems, their clients' money. CANDOR has shown to do that. It's reduced liability exposure. I'll get into that, some of that data, but we do not want to think about this or frame this or proceed as if our goal is to save money. Our goal is to prevent harm. And part of the way you do that is using a much better process to learn from bad things when they happen. And that only happens if you really support your staff and resolve things inappropriately. We also had a commitment to honesty here and to telling the truth when our medical care was not medically defensible, even if it was by stretching facts or doing many of the things that lawyers, and I should mention that I am a lawyer, do, to make something legally defensible. We wanted to focus on what was medically defensible. If it wasn't defensible, we wanted to be transparent, learn from it, and treat people the right way. So those were our goals. Next slide, please. I mentioned communication. It's the C in CANDOR. It's also that whirligig in our diagram, but it is really core to everything we do. So core to making CANDOR work, core to getting embedded in your organization is to really just figure out who your good communicators in the organization are and recruit them as coaches. We've learned in our work, and there are some really, really effective tools that are built into CANDOR that are very easy to use and that are highly validated over numbers of years about how to identify your good communicators. There are people who see complexity more than people who see things in more black and white terms. And there's tools to help you find them. Although when you find them, everybody goes, aha, we knew it was that person. We knew those people were going to be the ones that were assessed highly because they're such good communicators. The other kind of key bullet I want to bring out on this slide is the special colleague issue. When Tim McDonald, who's both a lawyer and a doctor, presents on this, he talks about the special doctors that we know exist in systems. And there are people that just don't have good communication skills. They might be really, really skilled in many ways. Our approach to communication is that everybody can get better. But part of the CANDOR process is to assess on a case-by-case basis whether or not the person who might be the best person to communicate in terms of being involved in the event that went forward or knowing the family just doesn't have the wherewithal to communicate effectively in that situation. We think those situations are rare, but we did acknowledge that there are going to be people that just aren't going to feel comfortable going into what's going to be, by all means, an emotional and potentially volatile conversation with a family member. So think about that C in CANDOR. It is absolutely core. I can't underscore that enough.
So, Marty, I just want to add 2 points from the patient side of things. I'm often asked, well, we had one conversation. The conversation doesn't end until the patient or family says it ends. And that can be days, weeks, months, or years, because you tell us something once doesn't mean we actually hear it after we've been harmed. So we may come back for many conversations because we have to find a place and a space in our hearts where we put this. The second thing, if I can teach you, is oftentimes people will say, well, when do we reach out? How do we reach out? You ask. You ask us. You can say, you know what, we'd like to talk to you, have this conversation. If we're not ready, you can say, can we reach you again in a week and talk to you? And you keep following back up that that's what you say you're going to do until we either say, don't contact us anymore, or yes, now, we're ready. We're in the right space to have the conversation. One thing I can tell you, I have never, dealing with patients, ever heard a patient say an organization over-communicated.
Okay. Thanks, Sarah. Okay, next slide, please. I'm going to move through our slides pretty quickly now. I think we've given you a good sense of the orientation and the reasons for CANDOR, so I'm going to walk you through it quickly. This is our biggest impediment. Rob referred to it as well. We are so used to just denying and defending. We're socialized to think that when something goes wrong, litigation is going to happen. I think the fear out there is exaggerated. That's backed up by data. But there is fear, there is shame, there is guilt. There's a number of things that go into the sort of way in which you just feel something in your organization. And we're trying to depict that here as our biggest challenge in implementing CANDOR. Next slide, please. Ali already referred to the wall of silence, but if that culture is in your organization, if that fear of being honest and the consequences of being honest, or of not knowing what you're going to say and whether you even have accurate facts happens, what we tend to do, what we've been taught to do, largely by people in my profession, law, is to be quiet and don't say anything that can be used against you later. And that wall of silence has horrible, horrible consequences for both patients and families. Next slide, please. This is one of my favorite slides that Dr. McDonald put together. He calls it the Unkind Cascade. But if you have that wall of silence, that approach in your organization where you just shut people up, you tell them you don't give them the answers that Carol would tell us that families need. Allie just mentioned it too. It's the way in which we just don't get answers. Many people litigate because they don't have information about what happened to them or their loved one, and that percolates through the stresses and strains on them into their families. At the same time, if we shut up our providers and say don't say anything, even when they're in emotional distress about what happened, we think that has a long-lasting impact too on their morale, their mental health, and some of the habits that they incur. So I love this slide. I think it speaks volumes. Next slide, please. I'm going to move through this pretty quickly, but Carol, interrupt at any time. We've got about 5 minutes left. This was our first picture to try to achieve the goals. This was our first design. This was really before patients came in and kicked the tires of this. This is what the docs came up with. Looking at an event, did it cause harm? If so, let's track it. Let's make sure that it gets reported. Let's do an investigation. If we decide that our care is not medically defensible, it was below standard of care, we apologize and we put money on the table. It was that straightforward commitment to doing the right thing that was the core of CANDOR. Next slide, please. We showed this to patients, and they basically gave us a lot of constructive feedback. One of them, Carol's already mentioned, but that's the importance of ongoing response. This is not one conversation we're talking about. This is a number of conversations. And it was also the sense that patients and families have basically a stake in this game. They really want to know what happened, and the show comes up in every survey. They really want to be part of making sure it doesn't happen to somebody else. So to do that, we really had to have a much more sensitive approach to those particular needs of patients and families. It wasn't just about disclosing. It was about learning to listen, not just to patients and families, but certainly to them, but also to our staff. When you listen more closely to staff, they remember more. They give you better RCAs, root cause analyses. Your ability to prevent things in the future increase. So next slide. This is
Marty,
Carol?
I'm going to just jump in real quick, and that is, you can never do a root cause analysis without involving family or loved ones or people there, because they're usually the ones 24/7. And we see things that you all don't see because you live in that environment. To us, we get to watch all of you. It's like a revolving door where you come in one by one by one. We see the whole movie, the whole story. So to think you can do a cause analysis after an event and not get our perspective, you're missing valuable information.
Thanks, Carol. So it was contributions like that, and Carol was very involved in this too, that helped us come up with a different design. So if you'll just kind of start with me in the upper right-hand corner. An unexpected event happens. We decide whether there's patient harm, and we immediately started an investigation to look at that. And part of that investigation involves early communication with patients and families. And then the place where this demonstration project happened, which is here in Illinois, we had an aspirational goal of talking to patients and families within an hour after the event happened, which meant that we had to have a report within a half an hour of the event happened to kind of get our ducks in a row and go in and start having a conversation with patient and family. To do that, you need a coaching system. You need that red box. You need people who are going to be on call to coach the people that are going to go in and have one of the most difficult conversations in their life with patients or family members that, may be in shock, they may be angry, they may be emotionally just melting down. You've got to prepare and coach and hold the hands of people to do that. The other key thing that I want to emphasize here is that patients and families told us, if you don't talk to us, as was in your original model, after you've done your investigation, you've missed what Carol just pointed out, and that is we have input into that investigation. We saw things that you didn't see. We managed things that you didn't manage. And oh, by the way, if you're not talking to us until your investigation is over, you've lost our trust. We think you're circling the wagons, and that's what prompts us to realize that we may need to protect ourselves and start thinking about litigation as well. So this was our model. Next slide, please. What it gave us was this blueprint, honestly, for how we were going to change the culture. And it focused just go on a couple of paradigms, but it's incident reporting. It can't be delayed. It's got to be fast. Communication with patients and families. Can't be deny and defend. It has to be transparent, open, listening, event analysis. We're not looking to blame. We're looking for all of the causal factors that go into it. Quality improvement, it's not just training. It's figuring out how people set up to fail. It's the whole human factors piece of it. Financial resolution, we are not going to wait until families tell us what they need. We're going to start that conversation with them proactively when we know that our standard of care has not been met. Care for the caregivers, we have to support them at every step along the way, and patient-family engagement, extensive and ongoing. So that is our blueprint going forward. I'm going to run very, very quickly through the data. And before I get into the data, I just have to say that when this was implemented at the University of Illinois, which is the first hospital here, they had significant CANDOR events within the first 2 years. So the data is one part of the story. I don't have the ability to show video today, but we have incredible stories of patients and families that have been through this process, felt incredibly respected, and just stepped up and wanted to work with the organizations to do it. So those stories of how we've actually helped patients and families heal or engage them to the point that they want to step up and be part of the solution, we have in spades. And I can circulate some video links to that if that would be helpful. But let me quickly get you through the data. So our event reports went way up. And this was part of our training, it was part of our rollout, it was part of our incentive, and we got a lot of buy-in. And for those that didn't buy in, that we knew weren't reporting, we imposed some requirements. And that was that if we hear about a report from a patient first, and not from the providers that were doing it, your organizational department gets a hit to their budget. So we built in not only some incentives, but some disincentives. Next slide, please. Our event analysis went way up. There was a commitment and involvement in this. Our reports were better. We found more and more things to look at in our quest to keep our eye on the puck and improve on. Next slide, please. This is all published data with the article you're going to see in a second. Our claims went way down. In claims in the United States, it may not be the same in every country. They're triggered by a letter or a demand from a patient or family. We were proactively, getting in front of that by putting remedies on the table before a claim was made in a court of law or in a legal context. So our claims went way down, and as our behaviors changed. Next slide, please. We also saved a terrific amount of money in liability costs from the point of intervention. That straight line in the middle of all these slides is the point of intervention, because we were able to resolve things much, much faster. We're compensating more patients and families, but doing it more cost effectively overall, because we were saving so much money on deny and defend practices, lawyers' fees, expert witnesses, all the things that drag things out for 6 or 7 years. We were settling things very, very fast. Next slide, please. This is the piece where a lot of this data is assembled. There are other articles as well. There's actually a whole list of articles I can give you if you'd like to see them. Next slide, please. I'm rushing here a little bit, Carol, because we're 4 minutes over, but I'm going to give you a chance right at a minute. We also saw, this is where the cost savings really came in. If the time to resolution went down so dramatically that we just saved money in carrying the claims forward. And then we began to see the benefits of our roles. We changed standards. We found ways to improve processes that came out of those better event analyses. And the big ROI is that our care for the caregiver was so intense that it really created a climate of trust and a culture of trust in organizations. Next slide, please. So we've now implemented in over 200 hospitals. It's actually closer to 400 since this article was written. And I wanted to just kind of give you a sense of what we learned from the process, from the people that we went in and implemented CANDOR in. Next slide, please. And some of these are kind of surprising. First of all, when you go into an organization and you talk about the need of communication, everyone says, yes, it needs to be improved. We found that disclosure policies were very variable. That's in red. We found that there was very, very little buy-in to including patients and families in root cause analysis. So that fear of what we're going to say if we actually sit down and talk and listen to patients and families and bring them into the analysis was tough. We also found that, this is very, I think, relevant to the COVID times we're in now, there was very little tracking of how different kinds of populations were impacted. We weren't analyzing our data based on race, ethnicity, or preferred language. and then without C-suite engagement, it just fails. So one last slide, Carol, and then you may want to comment on this as well, because frankly, this is a key insight that you helped many of us learn, and that is that we brought people like Carol into our training and into our assessment of organizations that were ready to do this. And we did that to really create a safe space where you could talk about these things. Carol will come in and talk about what it's like to lose a daughter. And the whole goal of this is to create empathy, to improve communication skills, to help people put themselves in the footsteps of somebody else. And that's what I think we accomplished by really bringing the family members and the patients themselves in as part of our faculty. I went over, I'm really sorry about that, but Carol, I'd love to get your sort of overall comments before we transition past our, to our next presenter.
So I'll make one comment before going to Joe, and that is we've done a great job of caring for the providers and realizing their harms. The next iteration is truly caring for the harmed families and patients. There's not programs and way to do that, and our harm continues for years because it's intergenerational oftentimes. So I encourage all of you to look at that next part, because once the conversation is often had, you think we're good and we're gone, but you don't track the long-term harm that Allison addressed early on, and we are tracking that for healthcare providers. So thank you.
Thank you. Back to you, Allie.
Thank you so much, Marty and Carol. I knew that these this is why we added an extra half hour. There's just so much to be said and there's so much interest. I don't know if you saw the chat box, it was just going crazy. I've captured as many questions as we can and we'll just move it over to the panel. So I'm hoping that everybody will be able to stay on for the full hour and a half. So without further ado, I would love to introduce Jo Whaling. So Jo is a research fellow and facilitator with the Diana Unwin Chair in Restorative Justice in New Zealand. She leads the collaborations with health sector partners, having worked as a registered nurse for 20 years in clinical, professional, and advisory roles, and within the healthcare organizations and international government agencies. Her area of interest includes restorative responses to healthcare harm, safety systems, and organizational culture. So I will turn it over to you, Jo.
Thanks, Ali. Kia ora koutou, everyone. Greetings from New Zealand. That little picture there was where I was meant to be sat just down the road from my house this morning talking to you, but I'm actually just a stone's throw from the Beehive here in Wellington. So I'm just going to check I can drive this presentation. And I don't want to minimise the voice of the mesh injured and their families by speaking for them today. So I'm actually going to focus on what Ali's asked me to talk about, which is how systems currently respond to harm, how restorative approaches differ, and then how we applied that in New Zealand in our response to surgical mesh. And when I say we, I'm talking about my team at the chair, the consumer advocacy group Mesh Down Under, and I know Carmel's on the line, and also the Office of the Chief Clinical Officers, which is as wordy as it can be, which contains our Chief Medical and Nursing and Allied Health Officers. So let's start with the problem. So Carol's just aptly described the problem's harm, and Don Berwick, who's the father of the IHI, he identified this way back in 2002, and the goal of the patient safety movement has been about eradicating it. And even the way that we define patient safety at the moment indicates that some harm that people will experience is actually necessary and acceptable. But who decides that? It's very much open to interpretation. And this definition by the World Health Organization has actually limited our understanding of harm and shaped how we respond to it. But it's actually talking about iatrogenic harm, which is the harm you get from medical and surgical treatment when you get a new injury, like a burn during radiation treatment. So there's lots of other types of harm in healthcare environments. There's the adverse events that we've been talking about today, which are actually defined as being unexpected, unintended, and unplanned, because we know that harm preceded by recklessness or conscious intent is actually quite unusual, but it does exist, such as Harold Shipman, for example. But we also have harm in the workplace, such as the deaths from lack of access to PPE. There's an increasing recognition of psychosocial harm associated with medical treatment for patients and families, but also for things like burnout and bullying, harassment. There's also more recently an understanding of the moral harm that occurs. So that might be a health professional not being able to provide a care that they would normally want to a patient, such as during the pandemic. But it might be what Ali and Carol described as this betrayal of trust following an adverse event. And we saw all of these types of harm in our restorative response to surgical mesh. And I'm just going to briefly, for those of you that don't know about surgical mesh, I'm just going to give you a little overview. And I just want to acknowledge if there's anyone listening who's been affected by surgical mesh, it's probably the worst harm in terms of scale and severity I've seen in my career. This is a medical device. It was FDA approved and used with limited research data and clinical trials in the mid-90s. And by the time the first product was recalled, the market was flooded with mesh products. And the harm mostly affects women because of its use in gynae and obstetrics procedures. But about a third of our 700 stories that we heard were from men who had hernia or abdominal surgery. And for many, the harm, both physical and psychosocial, it's life-changing. So to give you a sense of the scale, it represents one of the largest mass tort litigations in US history, and with payouts over about $8 billion. And I'm sure Carmel will correct me if I've got any facts wrong there, because she is the person I go to. Now, there have been national inquiries in the UK, New Zealand and Australia, and certainly in our health system. This is how we respond to harm, and it probably looks a bit like you would have in your countries. We've got these elaborate systems that are very hierarchical, and they've been designed to capture and respond to harm from different agencies, like having national incident reporting policies that intend to capture this information for system learning. And we've got some unique features in New Zealand, and I've seen some questions come up on the chat about what we have. And my international colleagues, including Ali and Rob, suggest that these features are fantastic. We've got a no-fault, no-blame system funded by the taxpayer, and we've also got a code of consumer rights enshrined in the law. But despite these magic ingredients, which some countries are thinking about replicating, the evidence from our three big national inquiries, we have one into mental health, one into mesh, and one into our entire health system, shows that they're not meeting people's needs. And I've got some thoughts why that might be. And I've seen some of these pop up in the chat. So although in the last decade, we've seen a shift towards patient and family involvement or engagement and a just culture within organisations, the evidence is suggesting that investigations into harm, and I mean all the types of harm I talked about, tend to focus on seeking causation, determining culpability, and punishing people. And it's because they ask these questions, which we call retributive inquiry, which is what rules have been broken, who broke them, and what punishment do they deserve. And these questions produce a really adversarial context, both within organisations and within these formal courtroom processes, where the evidence is presented and someone charged with responsibility of adjudicating an outcome on the basis of law or on the rules. And what it means is that instead of us accepting that there's multiple perspectives of an event, we actually have these competing stories, with one eventually being decided to be more worthy or more truthful or more accurate than the other. And as Carol said, patients and families will have very different perspectives potentially from a healthcare professional, and that's backed up from the research. So we end up with these investigations that are designed and led by someone who's considered to be an expert. We often decide what questions we want to ask at the outset. They're very much about retrospective document review. We seek expert opinion, and we want to identify and remove hazards, explore weakness and failure, and those most affected by the harm and not usually involved in the design of the investigation, the review of the evidence, or planning the response. And it means that we fix what we find based on those questions that we asked at the outset, and usually a judge or an investigator decides what harm is necessary and acceptable, not those that are most impacted by it. So we've got these policies that encourage open disclosure, and as Marty talked about, and that part of the process is really important. But we also know that harm isn't necessarily discovered just from within organisations. It can be reported by patients and families, regulators, lawyers, coroners, politicians, or journalists in multiple forums, and that was certainly the case in surgical mesh. And we know that those affected by the most harmful event often want to meet the people that are involved. As Carol just said, there's research as well that says that backs this up. But they're prevented from doing so because of this adversarial context, because of our concerns about legal, professional, and reputational risks. And we end up limiting the recommendations for system learning. They're normally quite weak for system learning. There'll be things like policy, audit, or training. And we end up with a prescribed apology. We don't end up implementing recommendations from those that are most affected by the harm and may well have some really awesome ideas about what needs to happen. So we know that in this current way that we were working, that these processes, as Ali said, they compound the harm for those that are most affected by it. What is evident in all of the reviews that we've had, certainly in New Zealand, is that we don't account for this ripple effect of harm because we're looking for system learning or holding individuals to account. And we unintentionally minimize the experience of those most affected by it by not thinking about the fact that this ripples out into people's families and communities. And that might be around trust as well for healthcare providers. And that is because I'm clicking the wrong button. we actually end up eroding people's dignity. And dignity, when I talk about dignity, I'm talking about Donna Hicks's definition, which is this inherent worth where we're seen and heard as though we matter. So let's move on to another piece of wisdom for Don Berwick. Understanding what led to a harmful event is important, but we need to think about the fact that people are also harmed and their relationships are affected. And to address the harm and enhance safety, we've got to restore well-being and repair these affected relationships and trust. So that means that what happened after the injury is of equal importance to understanding how or why it occurred. And it also means that we need to think about safety in a relational as well as a regulatory framework. And this is where restorative practices or restorative justice can add value because it's fundamentally about relationships. And you will know from your own lives that relationships make us human, they can harm us, but they can also heal us. So when in a restorative lens, we start by thinking of an episode of harm in terms of the relationships that are affected. And the approaches can be proactive as well as reactive because we understand that a harm response depends on this prior existence of respectful relationships. So when I spend time with my kids and then we have an argument, they're much more likely for that to be resolved quickly if I've been at home as opposed to if I've been away at work. It will often be much more difficult. And what we're going to talk about now is this real kind of pointy end at the top of the triangle, which is the response. So this distinctiveness of a restorative response lies in a combination of processes, of values and goals. The process involves a facilitated conversation between those directly involved in a harmful incident, both those harmed and those who have caused or contributed to the harm. The principles and the values include voluntary participation, respectful communication, truthfulness, accountability, empowerment, and equal concern. And the goals include clarification of what happened in the past, but also its human impact restoration of well-being as far as reasonably possible. And all those that are involved have equal voice and decision-making power about how to best promote repair and achieve positive changes. So we're aiming for a meaningful apology. So in restorative inquiry, personal stories are told in this safe space, in face-to-face conversation, and we try and understand what happened and then answer 4 questions. Who has been hurt and what are their needs? Who's responsible for the harm and what are their obligations? How do we put things right? And how do we prevent it from happening again? So it's not about abdicating responsibility. So a restorative response, in summary, is about inclusive, democratic dialogue, so equal conversation, guided by concern to address harms, meet needs, restore trust, and promote repair or healing for all those involved. So it's very different to thinking about minimizing risk to as reasonably practicable because of understanding the root cause. And because the philosophy underpinning restorative justice is based on humanistic values that have been shaped by religious traditions and indigenous worldviews, they're particularly important in our context because they honour our commitment to Te Rīpia Waitangi, and our current approaches can very much be associated with colonisation. And this is a quote from our kaumata from our mental health program. Okay, so one of the aims of a restorative process is to uncover these different needs, the justice needs for those most affected. So, for example, a mesh-injured woman my age might describe her substantive needs as being further surgery, but they might also extend to paying my mortgage, being able to work, look after my children, and have a relationship with my husband. Procedural needs might include understanding what caused my injury, but I might actually want to ask my doctor about the informed consent process. I might want my husband to attend the meeting, and I might want to be involved in designing preventative actions. So, and the psychological needs are around upholding my dignity and acting on what you take responsibility for. And my surgeon, the surgical team, and the hospital will also have these unique justice needs. And if you're thinking this sounds a bit hippie, restorative justice is one of the most researched justice innovations for the last 20 years, and our team works with all of these government agencies because of the successful outcomes. So I'm just briefly going to come back to MESH because I want to honour these amazing women. This is Charlotte, Patricia and Carmel, otherwise known as MESH Down Under, and they attempted to use government processes to get the severity and prevalence of harm from surgical mesh recognised for a number of years in New Zealand. And in 2017, the New Zealand Chief Medical Officer, Andrew Simpson, was assigned to lead the response. And they did a survey which indicated that people wanted to tell the stories to the government. And after a number of discussions with the Ministry and MDU, we were commissioned to design, deliver and evaluate a restorative approach. And our co-design team between the 3 of us was born. And our process had 3 phases. The first was we used multiple methods to collect people's stories because we appreciated not everyone would want to come and meet in person. They were all underpinned by restorative inquiry, so those questions. And we had circles in multiple locations around the country. And we also had a number of individual meetings for those who couldn't travel, including one in a hospital. And the circles had representatives from the different agencies responsible for harm or reparative action, 10 to 12 mesh-injured patients, family members and their support people, and 2 facilitators, an emotional support person and a researcher. And we also had a story database, which was used by the mesh-injured and their families and health professionals, who also had some telephone interviews. And we collected over 700 stories, and about 300 of those were collected in the listening circles. And a circle was a fundamental tool we use to create the safe space for empathetic dialogue. And rather than a free-flowing discussion, we sit in a circle which equalizes power relations. We agree on the guidelines and the values that are going to guide our discussion. We use a talking piece to confer speaking rights. We respond to questions from the facilitator that address harms, human impacts and needs, and we honour everyone's choice to participate in whatever way they choose. And these are some of the words that describe how the experiences of patients. You can see the trauma and the words people used: rage, devastation, grief, anger. Many have PTSD or have contemplated suicide as the harm rippled into their families and communities. Some people wanted individual clinicians to be held to account, but most wanted personal and family well-being and system improvement as their goals. And they told us about the systemic issues. They showed us very well they knew what needed to happen for change, but they also talked about how our current process really do compound the harm for people. We had a final listening circle where Mesh Down Under and all the agencies responsible for repair and prevention came together to act for change. The severity and scale of the harm was acknowledged, and the individual agencies committed to actions they would be responsible for. And we had a governance group to oversee and ensure those are delivered. And the anecdotal feedback is that there is high engagement with the issue, but some mesh injured and their families are still calling for a formal apology and want swifter action from the government. So my final slide is, obviously we need to evaluate this, and that's underway at the moment with my colleague Jill, who's also watching, which will be, we will end up with a descriptive evaluation for the ministry to understand people's experiences, and if we met the needs that people told us that they had at the beginning of the project. And then there is also my PhD, which is looking at it to understand what worked for whom and in what circumstances in order to be able to inform the future use. So I'm going to leave it there. You can read the report if you'd like to, and go back to Ali for questions.
Thank you so much, Jo. Yeah, the chat box is going nuts.
I know.
Trying to listen and see what's going on there. And I do just have one logistical piece I have to do before we run into the panel, and that's to quickly do this little poll that we have. Janet, do you mind sending that? And then we'll rush right. Oh, it's already right there. So if you guys don't mind filling out these poll questions, it would just give us an idea as to whether this information in this webinar resonates with you and kind of what your thoughts are. That would be great. And we welcome any feedback. And I know that any of the presenters today would be very happy to talk more. This is an area that we're all very passionate about. So I think maybe what I'll do while you guys are filling that out is just head to some of the questions that kind of arose during the conversation, and hopefully we can hit most of them. So this will be a rapid response, everyone. So one of the first questions that came up was, what do you do about patients who are afraid to say anything about care which they fear will cause harm, or providers who are afraid to say something about their colleagues? Lots of folks don't report for these reasons. So anyone who wants to jump in there? Is that something that you have had success with, Marty, Jo, Rob?
Ali, I would say that's often extremely challenging, and I know that speaking out as a health professional has been quite hard, and we certainly found in the MESH review that both patients and health professionals had not had great experiences when speaking up. I'm not entirely sure what the answer to that is. There's a number of initiatives that have been tried that haven't been successful, and I think the only way forward is to create these environments where we purposefully build structures within the system which ensure that patients are encouraged and people are encouraged to be open. We also know from the data around incident reporting systems that they're not well utilised, and there's lots of reasons for that. So I don't think there's kind of a one-size-fits-all answer, other than just acknowledging that it's very, very difficult, and encouraging people to do it anyway, because and to build a community around you that understand you and support you. because it's very, very hard to do the right thing.
What worked for us was just a very clear organizational commitment that involved an expectation that reports would be filed. So there was a lot of education, there was a lot of input about how important it was. We also set targets. So we said we expect to see this number of reports, and we built that into the residency requirements for students and residents. So their evaluations depended on them submitting a report, not necessarily about an event, but about an unsafe condition or a near miss that they would report. And with all that done, I mean, we spent quite a bit of time on that during the pilot project here in Illinois. That's where the stick came in. So it wasn't just carrots. And that was when we realized that we were not getting it from everybody, that we said, okay, if we hear about this from someplace other than your organization, your department, so it wasn't a personal penalty, it was a financial penalty on your department. So we kind of got them at that teamwork place. Your department takes a $50,000 hit to its budget for the year if we don't get reports from somebody in that department about something that went wrong. And, you know, that showed that we meant business. And at the same time, we were letting the cases of CANDOR accumulate and celebrating them when they went well. So we were starting to see us walking the talk and the results showing that when you're open and honest, you actually get benefits. It's not just the penalties that everybody's afraid of. And on the patient side, it's case by case. You've got to give people room to just get ready to communicate and know that they're supported. Simple things like giving them your personal phone card, personal business card with a phone number to call, and say they can call anytime if they've got a question or want to talk, helped for people who weren't ready to talk during a scheduled meeting.
Thanks. Did I hear Rob trying
I'll be quiet now.
Yeah. Yeah, I think with respect to getting providers comfortable to talk, that depends entirely on showing them through your concrete actions that your purpose is to understand the systemic and contextual factors that led to a particular problem. If they have any suggestion that you're interested in blaming, shaming, pointing fingers, they're going to be very reluctant to talk, and they're going to be very reluctant to report issues. So that's one of the things that we felt was we were fairly successful in with WRHA. Over a period of 6 years, we were able to get to the point where we were getting reports on almost 35% of the projected number of cases based on the large research done in Canada that we would expect. And so people learned just by the way we were investigating that, in fact, we were interested in understanding all these things. With respect to how you get patients and families comfortable, I think one of the key things is that you have, to the extent possible, a very active and robust participation through either a patient safety advisory council or some other kind of group. And we were able in WRHA for people who seemed reluctant to say, well, here are other patients who've had similar experiences. They're willing to talk with you to describe their experiences, and that would demystify to a great extent. So it is a matter of walking the talk, or talking the, well, you know what I'm saying, but actually demonstrating to them that, yes, the patient voice is important, because we have put together, at one point, our Patient Advisory Council had almost 30 members to it, and they did a lot of volunteer work with other patients who were initially reluctant. So you have to demonstrate your commitment to that concept by providing very concrete avenues for people to bring their stories forward.
Okay, thanks, everyone. So I'm going to kind of tie 3 questions, comments here together. So Terry has just noted that we need a just culture to deal with this. And I know that we had to circulate it around a research article not too long ago, Sydney Decker, talking about, I think Joe and Rob certainly will be familiar with this one, how difficult it is to implement a just culture within a retributive system. So and then Alika has just asked, how do you deal with the retribution that occurs to patients and providers as a result of reporting their provider or colleagues? And then I want to kind of also tie in a question. I'm making this really complicated for you guys. Hope you're on your game here. Not sure who may be best to answer this, but do you think that a no-fault compensation system would be the best way forward? Anyone got some comments on that?
Yeah. Now, Rob is always telling me I live in La La Land because we have a no-fault, no-blame compensation funded by the taxpayer already in New Zealand, and I absolutely think it's a great start because what we heard from Mesh Injured and what I hear from other consumers is that compensation is actually a really important piece of the puzzle. And it acknowledges those impacts that ripple out and affect so many parts of your lives when you are affected by healthcare harm, and the financial impacts there. But the trouble is if the process to access no-fault compensation is complicated and follows the same model that we have for investigations, where the burden of proof is on the consumer to prove that they have an injury, that the expert opinion is going to be based, and we heard this in MESH, on the research and the risks around the research. So actually, one of the things that had compounded the harm the most for our MESH injured New Zealanders was that whole process that they went through that denied them access to compensation. And the agency responsible for that is working with Mesh Down Under to change that process and to relook at previously declined claims, which is great, and that came out of the restorative justice process. But what I'm saying is, you know, it sounds like an idealized notion, but actually you still need to think about how do we have these conversations with people. There's still all those factors there, and I'm sure Marty will have some comments. In terms of how you implement just culture in a retributive system, I think we don't try and eat the elephant all at once, and that one of the things that we are working on at the moment nationally with all of our healthcare agencies is how do we weave relational safety framework in against one where you have regulation, because we don't want to have punitive action. We don't want to push information underground like we've just been talking about. I think there needs to be absolute commitment from the top, as Marty has discussed. There's an NHS trust in the UK called Merseycare who've implemented just a learning culture from Sydney's work, and they've actually reduced their bullying and harassment complaints from 100 to 28. Increase their reporting. They've had big financial savings. So I think it is possible with those commitments. And their advice was you have a board and a CEO who's willing to say sorry and to listen to people. And you have to build just culture into all your policies and procedures. And I think at the end of the day, for me, the next step is restorative justice. So when something goes wrong, we're able to respond in a way that actually really emulates those ideals. And I'll shut up now because I've talked a lot.
I'll jump in. What we found in our implementation is that just culture is important. We ask about it in our original assessment, and the assessment tool in the CANDOR Toolkit helps you understand whether you're ready to implement CANDOR. And if you don't have just culture, or at least the concepts there, you need to get it in place. I mean, CANDOR can help reinforce it. There's a lot of overlap with just culture, but it is important. We operate from the assumption that there is no fault, possibility of a no-fault system in the United States at the moment. So it's a great policy goal. I think it could help. You know, everyone is kind of enamored with what countries have been able to do with it, but it's not going to happen here. And so what we focused on was how the litigation system really doesn't work for providers. It seems like it does, but it takes 2/3 of every dollar spent out of the system and puts it in the hands of the transaction cost people. leaving 1/3 to go back to patients and families, and that's just an appalling system. For hospitals that have implemented, it involves sitting down with your lawyers and saying, look, our policy is not going to be to defend cases that are medically indefensible. We'll defend the cases that we can defend, that, you know, we know this, it was good medicine, good standard of care, but we're not going to do it anymore. And that's our moral principle. That's what we're going to do. And we're all going to sleep better at night, including you, if we're doing the right things by our patients. The top leadership is important, but we also, and Carol, I'd love to hear you kind of comment about this too. We go in looking for 3 different kinds of resistors to it when we're assessing whether an organization was ready. We've got nicknames for them. They're the assassins, and those are the people that really are absolutely against this, and you know who they are from the beginning. You've got to get them on board, or you're not going to be ready. We have the posers who say they support it, but they really don't. They'll go along to get along to see which way the wind is blowing, and then we have the saboteurs, and those are people that say they support it, but really work against it behind the scenes. So we look for those people and then put a lot of energy into trying to get them to see the benefits and to see kind of the blinders that they might have on that keeps them defending a system that doesn't really work for anybody. I'm not giving you short answers, but I hope that's interesting.
I don't know, Carol, if you want to jump in, but I have a couple of comments. And so I hear what you're saying, Joe. I think a no-fault option would be wonderful if we had any government, whether it's provincial or national, that had the courage to create the conditions to allow it to occur. And that would mean a moratorium on any role for litigation and confrontation in efforts to resolve conflict in healthcare, and to get rid of the idea that confrontation and litigation in any way promotes learning, and without learning, nothing can change. So if ever we had a provincial government that had that kind of courage and that would put into place a moratorium on litigation, say for 20 or 30 or 40 years, I think it would be possible to create those conditions. I agree that commitment from senior leadership is extremely important, but you have to ask the question, who really has an interest to change the system? It's the patients who are being harmed. The ones that we're bumping off, whether we mean to or not. Those are the people that have the interest. And you know why we're not yet seeing an effective coalition developing or a movement developing? Is we're not having the honest discussions with them. So I referred very briefly in my initial grid with the lost patient in the middle of it, that there was an imbalance in terms of risk and an imbalance in terms of resources. And when you work those figures out, the imbalance is absolutely obscene. There are 70,000 times more resources to promote safety from a legal point of view than there is to promote safety from the patient's point of view. And what we need to do is have an open discussion in society and say, how is it possible that we could allow this to happen, that we spend 70,000 times more human and financial resources to protect legal issues than we do to promote safety for patients? So it's really a question of who should be driving this bus, not the lawyers. They should not be driving the healthcare bus. And those are the difficult discussions we have. And as soon as patients across the country begin to learn the truth about what is available and what resources are being spent on, then we may begin to see a change. So yes, I would love to see a no-fault option, and I would fight for that very hard, and I think it would make a difference, but that requires huge courage, and it'll only happen when patients, the people who are being harmed, stand up and say, we're not putting up with this anymore. But for them to do that, they need the information, and we're effectively not providing them with that information. Sorry.
Thank you so much, Rob. Carol, did you want to? No. No apologies to me. I am completely in agreement with you. Carol, good? Oh, you're muted. You're talking away, Carol. You're muted. Oh, it keeps remuting. She's saying it's fine. Okay, there is one question I want to quickly get to. Oh, sorry.
I will say one last thing, and that is we are watching the liability insurance sector respond here. And the largest liability insurance company in California jumped on CANDOR really fast and is doing its own training programs, giving premium discounts. We've seen 2 other companies within the last couple of years step forward and not only do the same thing, but work with providers and patients to develop legislation that supports CANDOR. So we're watching those. I'm thinking of them as experiments, but it's really interesting to see the market move. And I think it's a recognition that CANDOR doesn't work for providers the way in which lawyers say it does. It causes a huge amount of trauma and distress and keeps people from sleeping at night. So that's encouraging.
Okay, I'm going to go to one last question. So curious if healthcare workers and patient families are brought together to talk about their experiences outside of the disclosure and facts and formal process. And if so, how do you set this up or operationalize it? And just a note that there is a project right now underway in Canada, yay, on how healthcare workers and patients and families might heal together through informal, genuine, and personal conversations. So just wanting to get a sense of whether that's something that any of you have seen or had good success with.
Did you want to say anything, Marty? Because I'm conscious that I went first last time.
Well, I always go long, though, so I'm going to be quick. The key to getting this to work and to get people to think differently is empathy. And so we just approach everything empathically. And it's why it's so that key insight I shared, which I learned from Carol. You've got to bring patients and families into the room as you're doing your culture change work so we can get to know each other and they can see how serious providers are and vice versa. And the empathic approach to talking to providers who might have been involved in an event and are afraid to say anything that might incriminate them or someone that they respect, that's empathy too. I mean, it's really having those conversations in a way where people feel like you understand them, you know what it's like to be them, and you're there to support them. And those are all, of course, parts of a just culture. So that empathy piece is important.
So I would say, Ali, when we've done it here, the most important piece is the preparation. It's really exciting to hear that you've got a project underway in Canada. The conferences that have gone wrong generally tend to be when there hasn't been that really good preparation beforehand to get an understanding of what all the parties' needs might be, because we have to ensure that no further harm is caused by bringing people together. So in terms of how you would operationalize it, I'm biased, so of course I'm going to say having someone who's an expert in restorative justice facilitation or some form of facilitation, whatever path that choose, that they're independent from the organisation in which the incident has occurred is also really important because it helps with supporting trust. And we've been talking about this a lot in the group that Carol and Ali and I are involved with harmed patients, is that idea that organisations investigating their own harm. So when it's severe, we would suggest use an independent facilitator, do really good preparation beforehand, and then do what you say, do what you commit to, because that's often the piece that falls down and reduces the possibility of harm, because it's worse, it compounds it because you haven't accepted the responsibility. Those would be my 3 suggestions.
Rob, any famous?
Yeah, I guess I would get back to Bishop Desmond Tutu, and I'm a big fan of empathy. I think that's great, and I think it's something that we need to take to heart. But you know, if I listen to you empathetically and I act in an empathetic fashion and I don't actually do anything about it, well, I still don't have my pen. Right. So we've learned the importance of communication and the way we respond to people, and then for a variety of structural and ideological reasons, I think we have trouble putting it into action, and that's what will sort of be the icing on the cake.
All right. Well, this is the end of our time together today. Thank you so much, everyone, for joining and all of these lovely presenters. Just a quick note, we are aware of some work being done in Canada in the Indigenous Communities and Research Commission by Patients for Patient Safety Canada and Canadian Patient Safety Institute to explore how patients and healthcare workers can heal together after harm, which is what I've just mentioned to you. And we'd love to hear from you, so please feel free to reach out to us. Let's keep this conversation going. Let's socialize these new ideas and look forward to next time. Thank you so much, everyone.
Thank you, Ali.
Thank you.
Thanks. Thanks, guys.
Take care.